All right, today we are tackling a bug that every single medical trainee has to know inside and out, Helicobacter pylori. Seriously, if you're dealing with patients who have any kind of GI issue, this is absolutely essential stuff.
But let's just kick things off with a question. Think about this. What common stomach bug, one that infects a massive chunk of the world's population, is officially classified as a Class 1 carcinogen? We're talking about the same category as things like asbestos and tobacco smoke.
Okay, let's get right into it. The answer, of course, is Helicobacter pylori. And as we're about to see, this is way more than just something that causes a few stomach ulcers. The implications are so much bigger. So, what is this thing really? Well, H. pylori is a gram-negative bacterium, and it's got this distinctive spiral shape. Its real trick, its little piece of evil genius, is its ability to survive in the super acidic stomach. It does this by literally burrowing into that protective mucus layer that lines your stomach wall. And that leads us to probably the single most important fact you need to burn into your brain about this organism. The World Health Organization, the WHO, officially calls it a Class 1 carcinogen. The takeaway here is so simple. When you find H. pylori, you are dealing with a confirmed cancer-causing agent, period. So that brings us to the really practical question for any clinician, right? When should H. pylori pop onto your radar? Who are the patients you absolutely have to test? Let's run through the essential hit list. Okay, this is your high-yield gotta-know list. So you're definitely testing anyone with a history, active or past, of peptic ulcer disease, or PUD. Same goes for gastric malt lymphoma. You also test after someone's had an early gastric cancer removed. But it doesn't stop there. The guidelines are also clear on patients with dyspepsia, either uninvestigated or functional, and people on long-term NSAIDs or even just low-dose aspirin. And then you have these fascinating systemic links. Think about patients with unexplained iron deficiency anemia, because H. pylori can actually mess with iron absorption, and even ITP, idiopathic thrombocytopenic purpura, which we think is linked to this bug through molecular mimicry, tricking the body into attacking its own platelets. This is your everyday, boards-relevant checklist. Now, just as crucial as knowing who to test is knowing who not to test. This is so key to avoiding overtesting, giving out unnecessary antibiotics, and just freaking patients out for no reason. And the clinical guidelines are super clear on this. And this slide is great because it puts it all side by side. It just perfectly illustrates where we draw the line. On the left, you've got our yes column. On the right, the no's. So notice, simple GERD if there's no dyspepsia is not an indication. And this is a big one, we do not screen asymptomatic people, not even if they have a family history of gastric cancer. This is how we stop that cascade of unnecessary tests and treatments. So, you've done your due diligence, you've tested the right patient, and bam, it's positive. Now what? Well, the goal is totally clear, complete eradication. There's no middle ground. So let's look at the principles behind this really aggressive approach. You can really think of the objective here in 3 parts. First, you have to get rid of the bug completely. That's step 1. Doing that allows for step 2, healing all the damage it's caused to the mucosa. The ulcers, the inflammation. But the ultimate goal, the real reason this is so important, is to reduce the long-term risk of that patient developing gastric cancer. We're not just treating symptoms here. This is true disease modification. This is cancer prevention. And hey, don't just take my word for it. This isn't some niche opinion. The strategy to eradicate H. pylori is backed by a massive global consensus. You've got major guidelines from Europe, like the Maastricht VI report, and from right here in North America, like the Toronto Consensus, and guidelines from both the ACG, the American College of Gastroenterology, and the AGA, the American Gastroenterological Association. They all agree on how important it is to test and treat this thing. Which brings us right back to the most critical takeaway of this whole discussion. Why are we so intense about treating this little bug? It all comes back to that undeniable, proven link between H. pylori and gastric cancer. And this is not just a theory, the evidence is rock solid. There is a landmark randomized controlled trial that showed that if you eradicate H. pylori in patients who've already had an early gastric cancer removed, you significantly reduce the rate of them developing a new cancer down the line. I mean, just let that sink in for a second. Getting rid of this bacteria directly lowers the risk of cancer coming back. This is exactly why it all matters so much. So I'll just leave you with this question to carry with you into your clinics. Based on everything we've just covered, are you really thinking about this Class 1 carcinogen in all the right scenarios? Are you testing the right patients to prevent the next case of gastric cancer?